So next I call upon Dr. Sandhya to present her topic on toric IOLs. Dr. Sandhya is a senior cataract surgeon at practicing at Giridhar Eye Hospital, Kochi.
So, toric IOLs in cataract surgery, how to optimize outcome. So, more than aim of modern cataract surgery is to give maximum free spectacle free vision to the patient and not just removal of cataract. So, around more than 40% of cataract population have a cylinder of more than one diopter. So, not addressing this during cataract surgery will cause patient dissatisfaction. So, now we have toric IOLs to correct up to 4.75 diopters of corneal astigmatism. So, proper patient selection and acquisition of accurate preoperative patient data and precise IOL calculation and execution of proper surgical plan are critical to optimize toric IOL outcome. So, suitable candidates are patients with regular corneal astigmatism of more than one diopter. Nowadays, we are correcting smaller and smaller amount of astigmatism. So, the first patient has regular with the rule astigmatism and the second patient there has regular against the rule astigmatism. So, dry eye and ocular surface conditions should be treated before taking keratometry measurements. Now, with the advent of optical biometers, accurate axial length measurement is not a problem. But measuring cornea is the major problem in IOL power calculation. So, we have to take these precautions. We have to treat the dry eye and ocular surface before measuring cornea. And patients with epithelial basement dystrophies and irregular corneal astigmatism, they should be avoided for toric IOL implantation. And high myopes are not good candidates, and you should have an intact capsular bag to provide rotational stability for the IOL. And you should measure the cornea before putting any dilating or anesthetizing drops. You should avoid drying, pressing, or rubbing of eyes. And you should take consecutive identical readings with good signal strength. And you should always avoid measurements with those warning signs. And you should also look at the Myers. If the Myers are missing or irregular, you should not take readings corresponding to that. The subjective refraction should not be taken for toric calculation because it includes lenticular astigmatism, so that is going to be removed during cataract surgery. So this patient with severe dry eye, and she was a rheumatoid arthritis patient, and she had a visual acuity of 636 best corrected visual acuity, and she was planned for a toric IOL, and her ocular surface was looking like this. And then after 3 days after punctal cautery, the cornea ocular surface improved and her vision improved to 6.9. So this shows the importance of treating ocular surface before cataract surgery. And whenever you should repeat the measurements if there is inconsistency between measurement, and if the steep axis is more than 47 diopters and the flat is less than 40 diopters, and if there is high astigmatism of either eye of more than 2.5 diopter, and also if there is asymmetry between the eyes of more than 1 diopter. So topography is helpful in ruling out irregular astigmatism. Now that we have identified the suitable patients and we have taken accurate measurements, now let's move on to IOL power calculation. So basically cornea has both anterior and posterior corneal astigmatism, and anterior cornea has with the rule astigmatism and posterior cornea has against the rule astigmatism. So if you don't address the posterior corneal astigmatism, that will lead to overcorrection of with the rule and undercorrection of against the rule astigmatism. Some of the newer optical biometers and manual keratomies and a topography based system, they measure only the anterior cornea. So why is it important to measure the posterior cornea? Because of the concept that if it is not corrected, the with the rule astigmatism will be overcorrected and the against rule will be undercorrected. So some of the newer biometers, optical biometers like IOL Master 700, it can measure the posterior cornea also. So coming to IOL power calculation, the most widely used formula is Barrett toric calculator. So this is available free online in ASCRS and APSCRS website. So what you have to enter is, you have to enter the K readings, you have to enter the axis of the K and then the incision location and the surgically induced astigmatism. Then it will measure and give you the IOL power that is needed. and also it gives the axis of alignment of the IOL. And so it also gives the message of residual refraction if you place this IOL in the eye. Now the significance of surgically induced astigmatism is coming down because the incisions are becoming smaller and smaller, and also because of the concept of centroid. This was assigned a value of 0.1 diopter. So if the patient is choosing a premium IOL, what you can do is, inside the optical biometer itself, this Barrett Toric calculator formula is there in most of the biometers, Lenstar, IOL Master, etc. So you can put it into directly into Toric calculator. So if there is astigmatism and Toric IOL is needed, it will give a print like this. So it will give the power of the IOL and alignment of axis, etc. And if the no Toric IOL is needed, it will give a message that not appropriate lens model found. So in that case, you don't have to put Toric IOL. So if you get like this, you don't have to think about against rule astigmatism, with the rule astigmatism and all those things. You can straight away send the patient to counsel for Toric IOL. And this Toric IOL has some marks here that should be aligned with the steep axis of the cornea. And coming to the surgical plan, so these are the things that need to be done in addition to what is being done in a normal phaco. That is, you have to do reference marking. That is, the 0 and 180 should be marked, and this should be in the sitting position to take care of cyclorotation. And then you have to mark the steep axis of the cornea because the IOL has to be aligned in that axis, and then the IOL mark should be aligned with the steep axis of the cornea. So these are the, here I am using a bubble marker for reference marking. So when the bubble is center, you have to mark the cornea at the limbus as shown here. So then it will be 0 and 180. The bubble should be in the center. Now in this, it's a slit lamp based method. So the beam is rotated to horizontal position. And when the Purkinje image is in, ask the patient to look straight, and the Purkinje image is when in the center, you have to mark the cornea when it touches the limbus. Now this patient is lying down under microscope after reference mark. You can see here. So you should mark the cornea and not the limbus, because not the conjunctiva, because conjunctiva is mobile, and the rexus should be round and it should uniformly overlap the IOL so that the IOL position remains stable. And then the clear corneal incision should be very smooth without any ragged edges. And then rest of the things are normal. You have to do a hydrodissection, and the phacoemulsification is like a routine phacoemulsification. And when you are marking the cornea, you should avoid spreading of the dye and smudging, etc. And once the nucleus and the cortex is removed, the eye was filled with OVD, and then you have to mark the axis. That is the degree gauge on this ring is aligned with the 0 and 180 marks. Here the axis is 165 and the steep axis is marked like this. Now the toric IOL is slowly injected, and you have to rotate it clockwise as it unfolds, and you have to stop around 3 to 5 degrees short of the final desired axis, somewhere around 5 to 10 degree. And then you have to unfold the haptics completely so that it settles down well. And then you have to remove the OVD first from behind and then from above the lens, and then finally align the lens to the axis that was previously marked. And then you can just tap the lens onto the posterior capsule so that it remains stable. And also, while hydrating the side port, you should make sure that the fluid weight doesn't propagate under the lens and lift it up, because then there will be change of position. Then here, Virion image guided system was used for alignment of the toric IOL. So Virion, it captures the images of the eye and notes down the details of the scleral limbal vessels and the iris detail. And then it calculates IOL power, and also it makes a surgical plan and creates an overlay which will be projected onto the cornea during surgery. And then after cortex removal, so you have to fill the chamber with OVD, and then you can see here the axis of alignment in 104. So finally it gives that line 104. So you have to align the 3 dots along the line. So here the only one advantage is that you don't have to consider about the fading of the dye or the smudging of the dye spread and all, but it's a machine dependent thing. So machine, you can't depend on 100% always. And sometimes we'll have to customize the IOL. In this patient, So had a keratometry reading of 46.28 at 180 and 55.7 at 30, and astigmatism was plus 9.5 at 38 degrees. And the topography showed features of keratoconus, but since the astigmatism was regular, we went ahead with implanting toric IOL. This was a custom-made lens, plate haptic lens that was customized by the care group, and it has a hole there on the haptic that has to be positioned to the left side while loading the IOL and while injecting it. So this is a slightly heavy lens, it's a plate haptic lens, and that has to be injected very carefully. And then there is no need of axis marking because it is intended to be placed in the horizontal axis. So finally you have to align with the reference marks there. And then finally the patient had a visual acuity of 6.9 with plus 0.75 cylinder at 100 degree. So to conclude, right patient selection and a good preoperative assessment and a meticulous surgery generally ensures good result, but never promise the patient that we are going to give zero astigmatism. Thank you.
Thank you, Dr. Sandhya. I think that was a very beautiful presentation with the lovely videos. One point regarding that customized IOL. I think if we are ordering the customized IOL, toric IOL, we need to counsel the patient that it would take some time,
It
right?
will take some. Usually they give in 3 weeks to less than 1 month time.
Around 1 month.
Around 1 month time.
So that is one thing. If you're going for a customization, we need to tell the patient that they'll have to wait.
wait.
Yeah, wait for 3 weeks. Yeah. Okay. Thank you.